Hello and welcome to TB Ed Talks, a series from TB Fighters where we sit down with experts all throughout the world of tuberculosis and learn about the thing that they are the expert on, and then we ask them questions. My name is Tori and I will be one of your hosts today, and I'm going to let my wonderful co-host Eliane introduce herself as well.
Hi, I'm Eliane. Some of you might know me as TB Feathers. I am a medical student in the Netherlands in the quaint little town of Maastricht. And I am currently doing a rotation in pediatrics. And I am here for, I guess, the more technical side of things. And I will let Stijn introduce himself.
Thank you, Eliane, and thank you, Tori, and thank you, everyone, right, for the invitation to speak today. Now, my name is Stijn. I work for MSF, Doctors Without Borders, already for 6 years. I used to work for the MSF Access campaign. We know the type for the TB fighters, and we have done quite a bit of work on the Time for 5 campaign, also on bedaquiline. Since the 1st of January of this year, I moved to another part of MSF, which is a big project. I will briefly explain what the project is about. It's about TB in children. I'm very happy, Eliane, to hear that your specialization is pediatrics. So super glad about that. So I'm now leading advocacy work in MSF about TB in children. And I will explain in the slides. I won't say much more now.
Yes. So if this is your first time joining us, Stijn is going to give his presentation. And if you have any questions for him throughout that, put them in the chat. Our incredible mods will get them over to us, and we will answer some of those and some of our pre-submitted questions as well. And you can continue to ask questions throughout. We really appreciate that. So without that, anything else, I will hand it over to Stijn for his presentation.
Thank you, Tori. I will share my slides.
Oh, and you're supposed to stay for some announcements at the end. That's the other thing I usually say in this part.
Sounds good. All right. Do you see the slides? Oh, good. So, yeah, thanks again to the team for the invitation to speak today about TB in children. I think everybody knows that TB affects children as it affects adults, but we don't hear much about children in the global space when we talk about TB. So I'm very happy to take you a bit through the basics, I would say, about what TB does in children. What are the challenges? How does it differ from TB in adults? But very pragmatically. So I will take you how we diagnose TB in children, how we prevent, how we treat TB in children, what are the problems, what are the gaps, and then also I will also explain a bit, but also hopefully discuss a bit what we can do together to close those gaps that children with TB face to access care. So for those who are not familiar to Doctors Without Borders, MSF, I have just put together 1 or 2 slides about the organization. I think most of you know MSF, but just as a reminder that Doctors Without Borders is based on 3 pillars, actually, on how we work, how we function. It's about independence, it's about neutrality, and impartiality. And that means that we are striving to be 100% independent from any political or religious or military power, and that we treat every human being basically because it's a human being, no matter where they come from and to which power they could belong. And that's why, to be 100% sure that we can remain independent, neutral, and impartial, that's why MSF, Doctors Without Borders, is almost 100% funded by private funds. So we do not, on principle, accept funding from governments or other public entities just to be able to speak out when we need to, right? So this is important to know when we talk about advocacy. And the other principle is that, of course, we are a medical humanitarian organization, which means our core principle, our core vision, our core ambition is to provide medical care for people who have difficulties to access medical care in their context. And we see advocacy as a principle or a necessary component, actually, of how we can provide optimal medical care. So we also speak out what we witness in countries or in the global space to make sure that every human being can actually access the right care through MSF or in the countries. But it's very important that advocacy is a key component of how MSF is working, with, of course, the larger objective and the priority of medical care to people. So another principle, and then I will stop talking about MSF and move to the children. This is very important to know that MSF is really working and specialized to work in areas, contexts, settings, which are difficult to work in, which are unstable. And you can see here the graph that shows that more than half of our sites where we work are actually either in armed conflict, internal stability, or of post-conflict. And this comes, of course, with a couple of challenges, complexities, how we have to work. I will not go point by point. You can see them here. It's about getting access, right, to the right medical tools, to the right people, difficulties to forecast. We have to move sometimes from site to site, and also high prices of medical goods. As we expressed several times, it also affects how we can do our work. So TB is still important for MSF. So as you see here, the data, and I do think we are still the non-governmental organization with the highest number of people that we treat in our programs with TB. You can see here that we treat more than 23,000 people with TB in 24. You can see here also the breakdown of the top 12. It's not the only countries where we provide TB care, but just to give you a sense where we actually have our TB program, not TB programs, but where we provide TB care to people. So as you can see, it's mainly in conflict sensitive settings like Eastern Congo, Afghanistan, South Sudan, and other countries. So when we look to the children with TB, you probably know that the WHO published their 25 report with the global TB data. So these are data from 24. So thanks to the WHO Child and Adolescent TB Working Group, who, when the data is published, they make these figures to really zoom in on the children. Because if you look to the report, it's sometimes difficult to find detailed data on the children. So the Child and Adolescent TB Working Group in WHO, they are doing that work, and then they zoom into the data of the children. And you can see here the distribution according to age about the people who have TB and do reach treatment and those who are missed. In adults, we reach like 80%. So which means 80% of all the people, adults above 15 years old who have TB are actually notified to WHO to be on treatment. You can see under 15 years old, it's a different situation, right? We drop to 60%. And the worst is in the under 5, which means that half of the children which are under 5 who have TB disease are not found. They are not diagnosed. They are not put on treatment. When you look to TPT, which is TB preventive therapy, for people who are not familiar with TPT, this is a way, if you're a child and you live in a household, for instance, of a person, often an adult, who is confirmed with TB, who is diagnosed of TB, and the child is eligible for preventive therapy, then WHO say, okay, that child or any household contact basically of a confirmed TB case should get this preventive therapy of 3 months. I will have a few slides on prevention later, but you can see here the data. I mean, more than 60% of the people who should get preventive therapy don't get it. And I explain later what are the difficulties with prevention, but these are just some data from the WHO report from a few weeks ago to see, I mean, that children are just facing the largest gaps, right? And the issue is, and the concern I have is that we don't see much improvement. Here you see actually the trends year after year. So we see notified children below 14 years with TB going up, which means we find more children with TB. Of course, we have this drop in 2021 due to COVID, but then we catched up again in 2020 and 23. But you can see in 24, we go down again. And this is not related to the impact of the US aid or any other global financing cuts, because we will only see that in 25, 26, the data next year. But you can see that we stagnate. So it's not, when it comes to children, we are not in a very good position, let's say, and we are quite concerned about what the future brings. I will also take you through a bit of data and some thoughts about the impact of the global health funding cuts, not only from the US but also from Europe, what it could mean for the children with TB. So these are some basic baseline data about the situation when it comes to pediatric TB. Now, in 22, WHO has updated their their guidelines and their WHO guidelines for the management of TB in children and adolescents. And they have added quite a few of interesting and very important updates, recommendations for countries, how to do better, how to find more children with TB, how to treat them better, like with the shorter regimens, but also how to use shorter regimens, for instance, for preventive therapy. I will explain you the main new recommendations, what they mean in practice, and also what we do as MSF on those new recommendations. Now, the year after the WHO issued those new guidelines, we started a big project in MSF, which is called Test, Avoid, and Cure TB in Children tactic, where we aim to actually do 3 big buckets of work on pediatric TB care. First of all, to support countries, because if you download the WHO guideline, it's a book of 200 pages, and it has a lot of recommendations. So to guide and to also support countries to implement those WHO recommendations, and we focus actually on mainly on the diagnostic front, because you will see in the slides I will show, I mean, the main gaps we see is finding the children. So it's super difficult to diagnose TB in children. That's why we miss a lot of children with TB. And there are important new recommendations how to do better. So we support the countries by implementing those new strategies, let's say, that WHO has put forward into MSF-supported facilities in the countries, with the ambition, of course, to generate local data, local evidence, to then go to the government and say, hey, it works in our settings. Please incorporate it also in your strategic plans. The second bucket of work is operational research, which means a very well-designed, I would say, research study to generate additional evidence to support the WHO guidelines. I will explain later how we do that and where we do it. And then the third pillar, of course, and that's what I am coordinating, is the advocacy, to really make sure children are put at the center, but also to support national programs, to update their guidelines, to make sure they are implemented, and to find strategies and ways for ministries of health to be able to implement those guidelines. So if you want to learn more, we have a webpage, of course. Feel free to visit after the talk, maybe the webpage. Whenever you have any questions, any thoughts, feel free to reach out to us. Okay, now let's take it piece by piece, I would say. And first bucket I would like to touch on is diagnosing TB in children. So a few basics. What is WHO actually saying? What does it mean? But also, what does it mean in practice? So I think there are 3 big ways that WHO is recommending how to diagnose TB in children. The first piece is X-ray. It's still it is a very critical component on how we diagnose TB, also for children. The second one is molecular testing. So we look for DNA of the bug, and then also for for resistance markers through molecular testing, which means you need a machine, you need a sample, you put it in the machine, and it tells you basically if you have TB, or if a child has TB, or if ampersand resistance. We all probably know the GeneXpert cartridge. I will talk you through what this means for children with TB. And then the third part, and that's the new one that WHO came up with in 22, it's about algorithms, clinical algorithms. I will explain later why we need those clinical algorithms, but also how we use them and what they can do. So these are the 3 big buckets, I would say, in terms of how we diagnose TB in children. The first one is X-ray. As I said, it's still a very critical component to screen TB and to diagnose TB. The advantages of X-ray, chest X-ray, is a very high sensitivity. Yeah, so you can really find the people with high sensitivity who have TB or are suspected of having TB. It's not a confirmation because it's not a bacteriology test, but with high suspicion, high sensitivity, you can suspect TB. It has a low operational cost. You can imagine, of course, the investment is huge. To have like an X-ray, it's not cheap. But the operational cost per image is relatively inexpensive. The results are super quick. Right? You take your image and then you can have it in a relatively short time, your image. And then in the last years, there has been some developments for ultra-portable X-ray and hard to reach areas. So for those interested in these ultra-portable machines and also in the computer-aided detection, I have it in my next slide because I see it as a challenge. It has an advantage, of course, but for children, we are not there yet with CAT, so with computer-aided detection. But for those who are interested, we published an opinion paper last year in PLOS Global Public Health, where we analyze and explain the advantages, but also the challenges that we see in the field in implementing those ultra-portable X-ray machines and also the CAT. But there are significant advantages, of course, on in X-ray, and it's a key component of how we diagnose TB. Now, there are also a lot of challenges, and especially when it comes to children, it's super difficult to get a good quality image of a child. For those who have had an X-ray, you have to stand still, of course. You cannot move the whole procedure. You have to inspire. I don't know in English, is it inspiration? Yeah, you have to inspire, like you have to take a good breath. And you have to imagine if you're a child of below 5, super sick, and they put you in a machine, and the person, the nurse or the doctor is in the white coat, and then you cannot. I mean, it's super difficult to have like a child standing or lying very still, taking a good breath. So quality images from X-ray for children is not easy. Second challenge is that radiologists are often not super comfortable with interpreting and reading chest X-ray from children. I'm not a radiologist myself, but you need to learn it. It's not that you can do it when you have like experience in adults, that you just copy paste what you know from adults into children. Of course, the big things, yes, but it's really some expertise that you need to learn. And that's why you see often some inter-reader variability, the same image interpreted in different ways by different radiologists or doctors. And then computer-aided diagnosis. So that's actually AI software that helps you to interpret an X-ray image. WHO recommended for adults, not yet for children. And the main reason why this is not recommended yet below 15 years old is because we don't have sufficient data yet. So WHO, when they make their guidelines, they look to evidence. They look to all the data. They generally have their process of data and a meta-analysis, and they look into the impact. And for children, there are just not enough data yet for on CAT. We hope, of course, to see that coming in the next years. But at the moment, it's not recommended yet for children. And then finally, of course, it's expensive machine. It's a machine, and it often breaks. Well, not often, but sometimes it breaks. And then, of course, yeah, getting the repair done and getting it functioning in difficult settings is often, of course, a challenge. But this is, in a nutshell, some basic about X-ray, what it can do, but also what it cannot do yet for children. So let's move to the next one. Sure.
Stijn, I actually had a question about X-rays because in pediatrics we're used to being very careful with giving children X-rays because of the radiation load.
Mm-hmm.
Not so much for diagnostics, like we're pretty easy with that, but for follow-up especially especially in these long-term kind of diseases where follow-up takes a long time, which is going to be a very high radiation load in the long run. Is that a challenge that you run into? Are there any other good follow-up options available for children?
That's a good question, Eliane. I'm afraid I cannot have the good answer to that. As I'm not a radiologist, I'm happy to take it back to our radiology and say, okay, because like a question about the radiation, right, on children and how that works in follow-up. So I'm afraid I cannot give you that answer today,
Okay.
but I'm happy to reach out to our colleagues who are
Thank you,
much more expert on that, how they deal with that, if they have those questions from the field also in terms of how to use X-ray for follow-up in children. So I'll revert to you
Thank you.
as soon as I hear back. Sorry for that. Okay, then when it comes to molecular testing, you will probably all of you have heard from GeneXpert. It's the initial test together with mobile. We have thank God now a few options, but this is basically the standard way how you diagnose TB in adults is you take a sputum sample. So people cough up a sputum and then you put it into a cartridge, and then a machine detects the DNA of the TB and of rifampicin or other drugs for you. This is not as easy in children. So you have to understand that children become sick with much lower bacteria compared to adults. And we call that paucibacillary, which means that if you take a sputum, and most children cannot produce even a sputum, but if imagine you can have a sputum sample from a child, the number of bacteria from a child who is as sick as an adult would be is much lower, which means if you detect the bacteria through your molecular testing, I mean, you cannot reach the same sensitivity because just you don't have the same number of bacteria when you compare it to adults. So that's very important to know. The second is that clinical progression is often much faster, and especially in the very young children, and especially with those with comorbidities like severe acute malnutrition, which means you don't have much time, right? They progress, and I think Eliane is much more aware of the clinical progression and what that means clinically in practice, but it's really a key component with young children with TB. And then thirdly, the clinical presentations are often different, right? I mean, we can have children who don't cough, right? Because you think everybody with TB coughs, but it's not always applicable to children. And then, but they have like fatigue. They don't play anymore. They are like not how they should be, and that's also a sign of children who have TB. Now, when it comes to molecular testing, it is recommended by WHO to do a GeneXpert Ultra for instance, on samples of children. They recommend here for children, these are the list of WHO recommended samples. And I also put like in the table, okay, what does that mean in practice? For instance, expectorated sputum. So we ask a child to expectorate, to cough up sputum. This is almost never possible when you have a sick child of under 5 that they can produce or cough up sputum. A bit of saliva, but that's not sputum. So that's very rarely possible. You can induce sputum, which means that we make the children inhaling like, I think, evaporated saline solution so that the sputum becomes loose and then they cough it up. Almost never successful. This is not easy to do in a sick child and especially in the very young age. A gastric aspirate. I don't know if you know what this means. It's like a syringe attached to a long tube. You put it in the nose of the child, and then you go down to the gastric. Sorry, I don't know in English. Like when you to the gastric. Let's say gastric, and then you pull, and then you have your fluid, and then you put it in your GeneXpert cartridge. We try not to do it as if we can, because it's just invasive. It's not something children feel comfortable, and we try to avoid it if we can. Nasopharyngeal aspirates, just doing same, but here in the nasopharyngeal area, very low sensitivity, and then stool. This was in 23 and 22 also one of the main recommendations, new things that WHO has added to their guidance to test stool in for children. And the principle is very simple. They don't cough up the sputum, they swallow it. And that's why we see that we can pick up DNA of the bacteria in the stool sample because they swallow the sputum. So that's a new recommendation. I do think, I mean, we should use it because it has high sensitivity, and the sensitivity is low, but if you can have a bacterial confirmation of a child with a gene expert, you're 100% sure it is TB. So how does it work? I won't go into details. It's a very standard protocol. You have your fishes and you add it to your buffer that comes with the gene expert cartridge. The important thing is you have to sediment, right? You have to wait for 10 minutes. Otherwise,
Oh, I think he has frozen for a moment, or I have. Okay.
I think Stijn's frozen, yeah.
Yes. This is the fun part of technology. I have another question to jump in with after this one too, so hopefully we get him back soon. Yep. You know, I probably should have prepared something to talk about in instances where something freezes. I will add that to my list of things to prepare for live streams. Hi, Stijn. Welcome back.
Oh, sorry, I was kicked out. Do you hear?
Yes. It's all good. We'll get everything back up and moving again in a moment.
Slide.
Yeah.
Slides back?
So I have one question specific related to the gene expert testing, and you might be covering this later, but I want to jump in with this because we are, especially at TB Fighters, very, very aware of how prohibitively expensive those tests are. Is the expense related to the test a barrier for using that test in children, given that it's not completely effective? Do they not test children because of the cost as well as the lack of sensitivity?
It is. So you will see, and I have more data in the next slide. The sensitivity is not that great. I mean, we talk about here 38% of sensitivity, which means you miss a lot of children who have to, right? So you have to use a lot of cartridges to find the children, right? WHO is also recommended to use more sample types of one child, which means that's to the cost, to have like to try to have sputum to do a stool, if you also a nasopharyngeal aspirate sample. So it definitely adds to the cost because of the low sensitivity. We also know from many countries, okay, they have challenges with finding enough cartridges overall, right? And they often prioritize them for adults because this is the initial test that you use for adults. So it's definitely impacting how we diagnose children. But as I said, I mean, the sensitivity is rather low, so I will move in later in the slides to the clinical algorithm, and that's maybe where we can find solutions, because we have seen in MSF, this is really probably the best way for many children to diagnose TB is clinically through these WHO algorithms. But of course, we should try to find children and to get them confirmed using a gene expert, and then it comes to the cost story, as you say. Good. So here on the slide, you see like the sensitivities from that meta-analysis, bacterially confirmed respiratory samples. Of course, this is a reference standard, which which is used, but of course, in practice, you almost never have like a bacteriology confirmed respiratory, which means a sputum sample from a child. But for those who were successful, we see here a sensitivity of stool testing then of 73%, but TB case definition, which is then a composite reference standard, which can be bacteriology confirmed or another. Or another way to diagnose or to confirm TB, we see that the sensitivity is 38%. Now, what does that mean in reality? So we are implementing those recommendations from WHO in several sites. I will show you later. One of them is Maiduguri in Nigeria, and it's an inpatient therapeutic feeding center, which means it's a facility where we treat children with severe acute malnutrition. So that's one of the main risk factors, I would say, for TB. It's malnutrition in general, but especially for children. So we also implemented there or included in the operational research stool testing, and you see that we have found a sensitivity of 50%. Of course, what is sometimes reported in studies is often in context, which are not always exactly the same as really in routine care. And we try to generate data, what we see here in Nigeria in an inpatient therapeutic feeding center. Of course, these are children with severe malnutrition. I don't think in the meta-analysis, a lot of the stool data were in this important group of comorbidities, but we see here a sensitivity of 50%. So just to say, stool testing is still important, but realize the sensitivity is low, 50%. Okay? But if you can find a child which has a stool which is positive on expert ultra MTP-RIF, of course, you can be 100% sure the child has TB. And then what about these new point of care tongue swab tests? I'm pretty sure every one of you may have heard that this is something new. It's coming for those. At the Union, we were in Copenhagen in Denmark last week, I believe, and there was a lot of data on the new point of care tongue swabs. So that's something completely new.
About that.
Yeah, I can imagine. So that's definitely something to watch in general, I would say, for the next year, because you will see a lot of data coming, a lot of implementation also by countries, also by donors are on it, which is good, of course, because I believe it's a very important technology. It's really I will not go into too many details, otherwise we can fill the hour just on that. But it's significantly different than what we used to have right now, which is as the standard GeneXpert. The first difference, it can use a tongue swab, which is particularly interesting for people who cannot produce sputum. It's also true point of care. GeneXpert is not point of care. You need your electricity, you need air conditioning, you don't put it like just where you want it. This is different. This is really made for point of care testing, and the big difference is cheap, right? We talk about $200-300 for the device, and a $3.6 to $4 for a test, which is significantly cheaper. So this is good news. Also, the sensitivity and specificity in adults, because these are data from a population above 12-year-olds, is very promising. You can see here in the graph, when you compare to sputum extra ultra, which here is here at the bottom, which has a 94% sensitivity. When you do a sputum swab on this point of care device, you reach almost 90. So it's not the same as GeneXpert Ultra on sputum, but given that this is a point of care device with a swab-based system, this is not bad. When you look to tongue swab, of course, a sputum sample will remain the best sample that you can get for people like children, but also like people with HIV cannot easily produce sputum, and you can take a tongue swab. It's better than not being able to do your molecular testing. And you see here a sensitivity of 86, which is of course lower than sputum swab, but not bad at all. Important to note is this is data on populations above 12 years old. This was one study, a multi-country study. I'm pretty sure there are a lot of other data. I know that the WHO had this guideline development group for this class of new TB diagnostics in November. So we hope in Q1 next year that we see a recommendation from WHO on this new point of care for countries, whether it should be added to their national policy as a test to consider for diagnosing TB. We didn't see much data yet on children. For the data that we could see, and often prelim data, the sensitivity dropped significantly, which is not a surprise. Knowing that children face paucibacillary disease, so which means there are just much lower number of bacteria in any sample you get from a child. So this means, of course, also for these new point of care devices, sensitivity will be lower, but we don't have sufficient data yet. So that's also something to watch for next year. And this is a bit also one of the messages I want to bring here today is that, and you see it in the previous slide. So we have plenty of data. This is not the only paper. You will see there is a whole bunch of data and often on adults, right? Of course, it's much more difficult to include children into your evaluation study, but of course, these are important also for children. So they are neglected in a lot of these evaluation studies, but also in the R&D. And we basically need TB tests, which are specifically designed, because these molecular tests, like the tongue swabs, sputum swabs on the knee point of care, I mean, the sensitivity will hopefully be similar to stool, I would say. I don't know, but we will see next year if data become available, but it will not be like the same as the 80%, 90% that we see in adults. So it will help. It will be one of the tools that we can add to our toolbox for children, but it will never be like the only test that we can use to know whether a child is infected or has TB or not. So I do think that what we should ask to industry, but also to academia, is really to put the children in the center. And what we have seen until now is that many of those tests are made for adults. Sputum sample, and you test it on a molecule, and then I mean, developers think, okay, it will work on children, or it's just a copy paste, blah, blah, blah. But knowing what we have discussed now earlier, I mean, it's not the case. So you really have to center the children in your R&D and really start from a child. What is the problem? What are the challenges? And then take it from there. And I do believe more into biomarkers like hosts, like blood biomarkers, to be able to pick up also there. It might not be like 100% sensitivity and specificity, but at least start from a child and design your tests with all those challenges in mind. So that's maybe something as a community we can advocate for, to really put children in the center of R&D to develop new TB diagnosis, but also in the evaluation studies, that they are not always coming at the end, and then they have to wait many years before WHO updates their guidelines for children. Now, another and a third and last big bucket of recommendations from WHO in 22 was a new treatment decision algorithms for children. So what is a treatment decision algorithm? It's basically a guided scoring system for physicians, which are evidence-based algorithms to know whether a child is suspected of TB or likely to have TB and can be initiated on treatment. So that's a principle. Here are the two algorithms that WHO has put forward: one for settings with an X-ray, and one for settings who don't have an X-ray. So two different algorithms, and it takes you just through the whole step by step. When you have a child in front of you with suggestive symptoms of TB, then you do this and this and this, and then the core is basically this yellow box where you have like a scoring system, and then you account points to those systems. To those symptoms. And of course, when you have a chest X-ray, the weight of a chest X-ray which has with these signs of TB, of course, is weighing a lot. But then you have your total score. If it's above 10, the algorithm says, okay, initiate TB treatment in children. If it's below, they say, okay, wait or follow up. So that's the principle. So these are not just made by WHO on a desk, like designed out of the blue. This is really based on evidence that they evaluated and then added to their guidelines in 22. The advantage here for this algorithms is you don't need a machine. You don't need your if you have an X-ray, you have to use it, of course. But knowing the low sensitivity of GeneXpert on children, this just based on clinical symptoms is important. So because of the importance of these WHO algorithms, we have started a study. It's called the TB AlcoPet study in 5 countries where we provide TB care to children. So more than 1,800 children were enrolled. We did a study over 40 months. What we could see, if we use the algorithms by WHO, we see that we can double the number of children that we can initiate on TB treatment, which means basically we find 2 times more children with TB by just implementing and using these WHO recommended algorithms. And these are the sites where we have implemented it. And we also wanted to generate those data in populations where there was not enough evidence yet on these algorithms. And we talk about children with HIV. Often they are also not included in many of these studies. And also 2 sites or 2 countries, Niger and Nigeria, were specifically on malnourished children. What is the accuracy, but also what is the feasibility of using those algorithms in this population, highly vulnerable population for TB? South Sudan, we have hospitalized and ambulatory settings, and then in Uganda, the same. So we had these 5 countries where we evaluated these algorithms. And here you can see the results per country. And as I said, overall, we had an increase of the doubling actually from 1.5% as a proportion that we initiated on treatment of all the children coming in before the introduction of the algorithms, and it went to 3% after introducing the algorithms, which means we find 2 times more children. So you can see in every country, this is the dotted line is the start of using the algorithms. This is the end of the study. And you can see in every country, there was a significant higher proportion of children that we could start on TB treatment when during the study on the WHO algorithms. It's not one line. You see these drops, right? And this is because we plotted here the proportions. And often you see these trends fluctuate, I would say, based on comorbidities, but also on staff training. Sometimes there's turnover of staff, but especially many of the sites were, for instance, Niger and Nigeria were on malnutrition, and malnutrition comes in peaks. Yeah? You have your dry season, and you have like a peak that you know in advance. Okay, these months we will have a flood of children with malnutrition, and of course with the same staff. Of course, and you don't have to also screen and do all these algorithms for TB and those children. This is very challenging, and that's why you see some drops. And I have some lessons learned and some messages also on how to avoid that. But overall, in average, we see a doubling of the number of children that we could initiate on treatment by using these algorithms. This is operational research, which means this is a designed research study to generate new evidence or additional evidence, especially in those specific populations. What we also do in the project is not only doing that operational research, but also implementing, just implement it in routine care where we provide already TB care in children. And this is just to give you an idea. We are covering 12 countries, more than 50 sites, and we focus a lot on the integrated services, because if you have these vertical TB facilities, like in countries, sometimes you have like these TB clinics, right? And not many have pediatric wards, but if they have, yeah, this is very vertical, but that's not where you find most of these children with TB. You find them in the pediatric wards, in the general wards. You find them in these therapeutic feeding centers, because malnourished children are very sensitive to developing TB. So that's where you find it. And that's where you have to implement all those new tools. So that's what as MSF in those countries we try to do, is to implement it in many of, as much as possible, the facilities that we support, often MSF, but sometimes in collaboration with, or mostly in collaboration with MOH, and in those specific key populations and settings in integrated service. Now, integration is key. So the main message here is TB should be basically business of all of them, not only of the TB doctors, not only of the TB national program, not only of the TB reference clinics, let's say, or hospitals, but I mean, in a high TB prevalent country, if you have malnutrition projects, I'm pretty sure you have a lot of TB there. So it's about integrating your TB service, and these algorithms can be, as we have shown in the study, they can be used in those settings in therapeutic feeding centers. So that's really one of the key components we want to message. Is really, it should be a business of everyone, right? In every child health facility, you should think about TB, especially in high prevalence settings. Also engage the community, very important. Then staff and time. You have seen these drops in these graphs in the countries, right? And the main challenge with using those algorithms is to secure enough staff time, right? Also because people go from one project to another, or they move, and then you have to retrain again. So it's a constant training, constant retraining, but also, as I explained previously, to anticipate when you have like a flood of children coming in. For instance, this is a picture from Nigeria, one of these therapeutic feeding centers where we treat malnourished children. I mean, sometimes they get like more than 1,000 per month, and that's a huge number of children that come to the hospital. And then to ask the staff to keep on screening and using those organs, of course, that's more challenging. So to anticipate that, to make sure you have more staff during those peak moments, which are trained in TB, that could somehow help in those settings. Now, just two clinical cases, just to give you a bit of ideas of how to. These are two slides from colleagues from Niger. From Niger. So the first one is a girl. She was admitted in our hospital in Niger in very bad condition, as you can see in the picture, and it's almost clear from the picture. This is probably a TB with from lymph nodes, etc. But you have to know this child came to our facility with, I would say, like a book with a lot of data, a lot of information, like X-ray images. As you can see here, there were all type of lab results, all type of consultations in private sector, and they just didn't think about TB. They just forgot about to think about TB. And this delayed the diagnosis for this girl, like for one month at least, which can be quite dangerous for such small children. So it's really to think about TB, and it's not because you have like your lab result or your X-ray that people automatically look for TB. They think about other then they put it on antibiotics. It doesn't improve, then it could be this and this and this. So it's just a matter of thinking TB. And this is another example, completely different situation where there was a delay in diagnosis because of, I would say, a social factor. So this was a girl. She was admitted in the hospital in Niger. And the first thing the team always does is have a consultation and have an interview, let's say, with the mother in this case of the child. And the first question you, of course, ask when you see a child suspected of TB is there a TB person? Did you have like a person confirmed with TB in the family? Because often we see the source of TB infection, of course, in children is often within the family. So that's basically the first question you ask. And the mother said, no, there was, I don't know, no TB. There is no TB in the family. And then, of course, they did a whole algorithm screening, etc., and X-ray, and then confirmed TB, and then they initiated the child on TB. And when they explained the results to the mother, that it was indeed tuberculosis and that the child will be treated and will be cured, she started crying. And then she said, okay, the brother of that child died like a few months ago of TB. And the mother was just, I mean, she doesn't want to hear anything about TB because it was so traumatic with the older brother dying of TB that she said no and didn't want to hear the word TB. And that's why, that was also a delay in diagnosis, because if people say it's that there is no contact, of course, while it is true. And this is just because it's very important, I think, to put really the people in the center, during your consultations, and really listen to the people, and don't treat the lab result, but really treat the person, and to listen and to understand and also anticipate a bit on challenges that people may face. And there's a lot of stigma on TB as well. So these were just two, I would say, real life examples, what it really means to diagnose TB in children, what are the challenges. And it's often not just that the gene expert is not there or you have low sense. It's often these type of human stigmas, human challenges that you may face to find TB in children. One component that is very important, and I also definitely want to bring the message here today, is about nutrition. Malnutrition is the key, I would say, one of the dominant factors, and especially in children, why you develop TB disease. And I believe when we talk about TB, I think in every 5 sentences, we should at least say something about nutrition. And for children, we should almost say it in every sentence, because it's so key. How we can do much better is just to make sure people are not malnourished and that they have the food support. WHO has released very important guidance a couple of months ago on the 8th of October about exactly this, and that every person who is treated for TB should also get food support, but also very important, food prevents TB disease. So every family which has a confirmed person with tuberculosis should get food support. So this is a very important recommendation, I believe, from WHO that we also try to support from MSF. But there is a link between nutrition and disease. And this is a slide or a few pictures from our project in Manila, where we have active case finding. So what we do, we go into the communities, try to find, with everything I explained to you today, we try to find the children, but also the adults who have TB. We refer them to treatment centers from the Manila District of Health. But then recently we also added this food component, and this is done by the team in Manila together with a local NGO to really make sure that, and these are poor people, and they often don't have like the same meals as we could provide, and that's what we do with this local NGO to make sure the persons who have TB, but also their whole families, do get food support. So, and we do that because, I mean, food is the best prevention I think we have for developing TB disease. John was in Manila, so he visited the project. I think you have seen some of his stories about that. Just wanted to make sure you understand indeed the importance of nutrition when it comes to preventing TB, but also especially in children. Then very short, I talked a lot about diagnosis because this is really the main gap we see in countries. When it comes to pediatric tuberculosis, it's really to find them. We are very lucky we have now shorter regimens that are also applicable for children to prevent TB. In the next slide, I will show you also for to treat TB of all ages. So the 3HP, 3HR is now recommended by WHO as a preventive therapy for children of any age. So any child who is eligible for TPT and is a contact of a confirmed person in TB in his family or household should get TPT. And as I said in the beginning, we see the data here with more than 60% not receiving it. And that's basically, it's not that easy. You have to go out of your hospital, out of your lab. You have to find those household contacts. It's a lot of community work. It's a lot of going into the communities, finding those families, doing this investigation for eligibility criteria, and then make sure they follow that therapy, preventive therapy for 3 months. And you have to imagine these people are not sick. This is to prevent they become sick, and then to convince them to use those therapies for 3 months. It's not easy. It's a lot of community. It's a lot of social work, and that's of course much resource dependent, and that's why we probably don't see enough coverage of TPT. When it comes to treatment, WHO now recommends short regimens, like 4 months for non-severe tuberculosis in children 6 to 9, the laminate pelataquilin, also for children of any age. We also have pediatric formulation. Thank God, it also took quite some time to have those child-friendly formulations. We don't often see them yet, or not enough, I would say, in countries. We see a lot of stockouts, especially for the pediatric formulation. But based on the WHO guidance, you can treat children for non-severe or drug-resistant TB with the short regimens. Now, it's not because WHO has recommended them that we see it in every single hospital that we work in. And so we face a lot of stockouts. And I have to say the pediatric formulations often are still somehow more expensive than the adult formulation. So this is often the first line, I would say, that MOH has to cut because they face like these type of budget constraints is often in this type. So yeah, the main message here is not because we have those formulations that we see them in all the countries. So it's a lot of advocacy in countries to make sure that every child can have access to the right treatment and those preventive therapy. And that's maybe one other point that I wanted to explain here, how we work as MSF in those countries. So we do have our medical work as we have, as I have showed, and our facilities often together with MOH, but we also want to make sure that all children in a country has a right to access these new technologies, these new tools, these new treatments, and that's why we within that tactic project we work a lot with the national governments, and this is an example from Niger where we had a round table also in November, beginning of November, where we brought together all the stakeholders working in child health in Niger into the same room for 2 days to discuss about TB in children. And I have to say it was very successful. And we made sure it was not only TB persons there, it was also the nutrition, the nutrition folks, also the child and maternal health, also community. We had to be survivors. And that's really what I think we should do, is really to make sure we don't talk only to the national programs of TB because they know it, right? They know everything I said. They know they have challenges, but really to involve also the nutrition departments in the MOH, nutrition partners like the World Food Program and others, pediatric services like the general pediatric services and departments, etc., to really make it multi-sectoral, because they can do a lot, because many of these children which we cannot diagnose are in their services. It's not in the vertical TB clinics, as I said in the beginning. So it's really important to also talk to those other sectors outside TB vertical programs. And then keep in mind, TB programs often in MOH are often 100% dependent on external funding. So this is also a challenging moment for the national programs, for instance, for Niger. And they said, we really need the help from other departments, other stakeholders, and to be able to keep up the speed that they wanted to have. And this brings me, of course, to the funding costs. I don't think we can end the talk without briefly touching on what we face right now, which is not optimistic, not very, I mean, not very sunny times, I would say. It's challenging for a lot of programs. And of course, every program is hit. Every person who is living in a TB, HIV, or a malaria, or any other context with high prevalence of these diseases, which are for which the programs are heavily dependent on those external funds. I would say that children with TB are probably one of those populations which are hit hardest. As I said in the beginning, they face already such a huge gap to even reach proper diagnosis. It's also the first line, or often that countries have to delete from their Excel sheet, because they don't find a lot of children. It's super challenging, right? As I explained, to find children. So it's often the first line in the Excel sheet that is get deleted. And there is an interesting paper. Of course, it's a theoretical modeling, and modeling is modeling, but at least it gives you a sense what it would mean in 10 years time by 2034, what the current situation of US funding cuts. I would take it broader also with the global fund replenishment. We are not there yet. And also because of many other non-US, also European countries shifting away from this global aid. But this would mean, you may know from the WHO report, now we have 1.2 million children with TB. It would raise to additional 9 million. Now we have 200,000 deaths in Chad. It would raise to 1.5. These are data that we can use, I think, when we talk about not US, but in general, the global funding cuts when it comes to children. So keep this in mind. This is a mathematical modeling. If we don't do anything, this will be the situation in 10 years time. Then
Can I ask a question? There was a question in the chat actually about the funding cuts. Camille asked, well, first I asked how it's specifically affecting children, but I think you answered that. But then they also asked, how long will it take to right the ship if the funding is restored? And if not, then what's the future outlook?
Yeah, that's a good question. I mean, I think we can learn a lot from COVID, and you have seen maybe in the graph, we had that drop, right, in 2021. Do you remember that? Like this drop during COVID? I think it's very similar, right? You see services cut at that time because COVID, because all the labs, all the hospitals were full of COVID, and then they shifted away from TB. I'm pretty sure in 25, 26, we will see the same. And then hopefully we go up. And we went up after COVID because COVID is not disappeared, but at least the burden was much lower in 23, 24. And then you can see we can recover again. But this is on the condition that we recover from this funding cost, which means we go to the same levels as 24. And I'm not 100% sure we will get that like in a few years. So if we don't recover on the same level, and we need more, it's not that getting to the same level is enough. We need more. I mean, we will go down, 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 down. But if we get to the same level, you can see in the graph, we can get back quite. So it's possible to recover quite quickly because the services are still there, people are still there, or the knowledge is still there. But of course, the longer you wait, the more difficult it will be. So I hope that answers. Of course, I cannot watch into the future, but I hope it answers something
Yes,
what we can expect. Good. Okay, this is the Union World TB conference. Just to, yeah, these are some nice pictures. I wanted to just say, okay, we at the Union, its conference is the World TB conference. It says it all as people, experts are there working on TB in one place to share data, to do exchanges. So civil society is there. We took the stage during the opening, as you see here in the left picture, and of course with a lot of messages from communities, especially on the funding, because community, civil society, community organizations are also heavily impacted by the funding cuts. But then we also brought a message about TB in children. We had these panel discussions, and the lower left picture is an interesting one because there we brought together really different sectors, different people, let's say, who are working on child, but from different sectors. So we had the National TB Program unit head of childhood TB from Nigeria. So one of the national programs was there. We had a man from India who works around community work on nutrition. And then we had also Annie, which is a mother of a child who survived TB, is a TB survivor as well. Then we had doctors. So, and one of the messages here that we learned from that session was really we need more tools to translate and educate and give tools to the communities to go to their governments to advocate for more resources for the children with TB. So we face a bit that gap that we have a lot of medical things. We have the WHO guidelines, but then when it comes to informing communities, what it means, we lack that. We don't have like those tools yet, and that's what something I would like to work on in the next year, really to make those tools that can be community-based and used by communities to go to their governments or to at least advocate that the children should have proper access to diagnosis and treatment. So this is from the Union. I will end here. So this is also a plea maybe that we need you guys just to be together when it comes to pediatric TB. I know the TB fighters, thanks to the Time for 5 campaign, very well, and also know the power. So I do think we can think of ways to what I try to explain today to make sure this is also reaching other people, right? Like in terms of social media content, specifically on children, and maybe on some key dates, maybe not every day, but at least on some key dates along the year where we want to put the spotlight on the children with TB, but then also some core messages. What do we actually ask? Whether for anyone, and we can discuss later, of course, on the practical ideas, what we could do together. But that would be really good to have, like in the next year, let's say, also some content together on the children with TB, because it's, I mean, everybody loves children, right? But when we see like the graphs, it's a pity that that they face the largest gaps, and it's just because they are forgotten often. And that's we have to restore, and we have to say, okay, we have a problem there, so please do something. Anyway, we can brainstorm later. I will end up here. You have my contact details. Feel free to use the slides, to share the slide story with the group if you, but anyway, it will be online. So thank you very much. I hope, it was informative. It was useful. I'm happy to answer a few questions. And then also looking forward maybe to the future to work together on this.
Yes, and we're so grateful for having you here. So we have a couple of questions. I know we're coming up on time, but Eliana, do you want to start?
Yeah, so we got a question in the chat from Untapped Inkwell about the difficulty to acquire diagnostic testing. And they asked, is that difficulty in diagnostics, does that also result in a higher mortality rate for children with TB? And maybe how does that happen?
Yeah. So definitely. I mean, if you don't diagnose TB in a child, I mean, it's very likely the child will not survive because of the TB. So there is for sure a direct correlation between missing diagnosis and mortality, which means I mean, for the 50% of children who are missed by TB, of course, we don't know because they are not notified. But we're pretty sure many of them do not survive TB disease if they are not diagnosed and put on treatment. Also because, I mean, their immunity, I mean, their capacity to deal with TB is much lower than in adults, often also due to these comorbidities and with malnutrition, etc. But there is a direct correlation for sure.
Mm-hmm. And we have another question here that asks, what are the barriers to including children in the center of some of this R&D? Does it make the studies more complex, or is it an issue of profitability or ethical concerns, or some combination?
Depends a bit where, I mean, in the upstream R&D, for instance, with industry, right? Where they like Safir, but then you also have in China a lot of these companies, or in Korea, like making new diagnostics, very, very promising technologies. When we as MSF talk with them and say, okay, what about children? Did you think they just don't know? They are not aware why TB in a child is different than TB in an adult, right? So they are not thinking about children in the design. And I really believe they should really start from the children. Do you still hear me?
I still hear
Yes.
you, yeah. You're just frozen.
Well, we could, and unfortunately now we can't.
I jinxed it, I'm sorry. Oh, no, he's back.
We did it. Oh, now he's back.
Sorry for it. It's a bit up and down today. I took off the slides because you have seen them. Maybe that helps. So it's just because people often don't know the specific challenges of TB, and especially in the upstream R&D. Of course, I mean the academic groups who do the trials and the studies. Of course, there it's much. I mean, it takes additional efforts, I would say, to include children. Also, ethically, you have to take some things into account, but it's not impossible. So it's often a lack of understanding, I would say, especially on the upstream R&D when it comes to data generation. And of course, yeah, it's more difficult with children also because you don't have your golden test, like culture also is often negative. So it's much more difficult to generate data because of the nature of TB in children. But of course, shouldn't be a reason not to generate data if you can.
Thank you. I think that gives a very clear overview of what's going on. And then I also had a question because something we deal with in all of pediatrics is the issue that most medication just doesn't taste very good, which sounds a little trivial, but it's actually a very big issue because you're not going to get a child better if they're not going to take the medication, and if they don't want to, they won't. And then, of course, in TB, that's even a bigger issue, maybe because it's such long treatment regimens, and these children have to keep doing something that they don't want to do. So is that an issue run into? And then also, are there any best practice solutions in the field that you've come across or that you've heard about that can be implemented?
Yeah, that's a good question, Eliane. I think, of course, you have these pediatric formulations, but you have also child-friendly formulations, which should be more friendly for the child per definition than formulations which are not child-friendly, or even the adult formulations where you have the pills and then you crush it, and we know they taste awful. For those who missed the panel discussion with John Green on the 12th of November, we had Ani Hernasari from Indonesia talking, and she explains it super well in the panel there, what it means for her, but also for her child, what it means to force her child, like for 6 months or even longer, to take adult formulations crushed. And I mean, as you say earlier, it tastes awful, so they throw it up, and then you have to restart, and you're not sure about the dosing anymore. So it is an issue. I'm afraid because pediatric formulations often, or sometimes they are not available, and then you have to go to the adult formulations. But then, of course, there's no magic trick, I think, and not that I'm aware of. So I think it's just, I mean, every child should have like the right to have child-friendly drugs, and of course, it's challenging in countries, but that should be the ambition.
Yeah, absolutely. Thank you.
Okay, I think we have time for about 2 more questions. So this one was one of our pre-submitted questions, and it asks, what can be done by advocates to encourage the development of diagnostic tests and perhaps better tasting medication that work better for children? What can we do and how do we start?
Yeah, that's a good question. I mean, it depends a bit. I mean, there are different methods, right? So what we often do is talking with the industry. Because we procure a lot of tests from many, and then we say, okay, what about TB and what about childhood TB? And then we try to educate them. It's a lot of education. And so I think what we can do as a community is if we put like very straightforward messages into the space, okay, childhood TB is not the same as adult TB. Think about this and this and this, that you don't come up with a new diagnostic test for children based on sputum. I mean, it will not work because children never, I mean, at least like the young population never produce sputum. So these type of basic informations, I think I will be very happy from MSF to give you like the content that this is translated somehow in materials that can be taken up, that can be shared over social media, but also through direct emails, but just educate like developers about the basic principles of pediatric, but especially what do we need? What do we need in terms of diagnostics for children? It's non-sputum. It should be sensitive enough, etc., and should be also work in settings outside the laboratory. Yeah? So, but we do have our wish list, of course, and happy to provide you with content. But I think it's really speaking and putting it in the spotlight. And the more we say it, the more people will hear it, and the more hopefully they will do about it.
Yes, and we would love to learn more, especially about this topic and how we can help, and also what the impact of some of these changes would be, right? If we are able to improve that testing, having that outcome there and that goal is also something that we would love to hear about, which kind of leads us to our final question that we've been asking all of our guests, which is, things are very bad right now, especially in the world of global health, and just in general, health in children, it is difficult. What are some things that are giving you hope right now? And Eliane, I'm going to ask you the same question in a moment.
So where the hope is, where I see hope, I think what we see in the communities, and also what I see here today with you guys, like this keen interest to learn about TB in children. When we were at the union, when we talk with the communities, with the people on the ground, they face a lot of challenges, right? With not sufficient funding, with those huge gaps they see in pediatric TB care. But I think it's really, the hope is really in those people, right? We have to make sure, just as a community, that those hope can become reality. But my hope is really into the caregivers and also as a community, TB community, what we can do. And no matter what challenges we face on the funding, I believe the hope should always be there. And we look forward to better times when it comes to funding, but also to tomorrow, because we can already do a lot tomorrow when it comes to making sure every child has access to proper TB care.
And Eliane, working in pediatrics, I would love to hear from you on that, and also how you put that hope into your patients.
Oh, well, I don't think, well, I hope I give my patients some hope, but I think mostly it's the other way around. Stijn talked a little bit about how disease presents very differently in children. And that's not just TB, that's most diseases present differently in children. Children can get sick very quickly, but they can also get better very quickly, which is what I love so much about pediatrics, is they just turn around so quickly. And that's mostly physiological processes, of course, but I think there's also something just about the way children are, where like they can be running around with high fevers and if they don't feel sick, they're just gonna get up and play. And I think there's something very hopeful in that. And then in the global health space, it's always been TB fighters that gives me hope. I've been with you all for like 3 years now, and it's I've been in global health for a bit longer, and it's very, very unique what we have, and I'm so proud of everyone. So that gives me a lot of hope. Yeah.
Well, that is wonderful, because I think that's something we all need to hold on to all the time. So Stijn, is there anything else that you want to share before we start wrapping things up? Because I've got 2 announcements to make at the very end of the stream.
No, thank you very much to you, Tori, to Elian, to the whole team, but also to everybody who joined us today. And yeah, let's keep the hope and turn the hope in reality. And I'm pretty sure we can do a lot.
Yes, and keep us posted. We're always excited to hear more about what's happening and how we can join in. So 2 quick announcements before we wrap up. If you are watching this stream before December 7th at 11:59 p.m. Eastern, you live in the US, you can still apply to join us at Hill Day in DC. We are going to be joined by TB survivors, experts from around the world, and some guy you might have heard of named John Green. So we are going to have as many meetings as possible with US legislators, making sure that they are aware of everything that is facing us as a problem in the world of TB. So if you are available, we would love to see you there. And I will also share that our very last TB Ed Talk of the year is going to be happening on December 17th at 7:30 p.m. Eastern. And this is going to just be a review of 2025 in TB and TB fighting. So we're going to be joined by Rosie Pauling and Vincent Lin from Partners in Health and some other special guests. And it's just going to be a great way to wrap up the year, and again, think about all of the progress that we are still making even when things are difficult. So on that note, I think we are all set for today. And as they say in our hometown, don't forget to be awesome.
Don't forget to be awesome.
All right, thanks everyone.